So I would like to welcome Dr. Cohen to our event this evening. Dr. Cohen is a behavioral neurologist, and she's known for her excellence in patient care, teaching, and clinical research. She is the medical director and site principal investigator for the Toronto Memory Program, which is a community-based facility she established in 1996 for the purpose of enhancing diagnosis, medical care, and therapeutic options for people with or people who are at risk for Alzheimer's disease and related disorders. Um, and her memory clinic and her research site are certainly among the most active in Canada. She has 28 years of experience in clinical research. In addition to her focus on Alzheimer's disease, she has also participated in and is very knowledgeable. Um, and she's participated in pharmacological trials for stroke, frontal temporal dementia, Parkinson's disease, dementia, Lewy body disease, Huntington's disease, and vascular dementia. So she's very well rounded in her knowledge base. She's a frequent lecturer and she's known for her advocacy for individuals with neurodegenerative disease. Despite holding, many academic and hospital appointments, Dr. Cohen chooses to practice in the community, um, and in keeping with her belief that dementia care and clinical research are best offered in the real world setting. And we are so happy you're here tonight in our real world setting. We are really excited to hear what you have to say.
Thank
So
you so
welcome.
much, Jeanette. Thank you. It's wonderful to be here. And I will try and share my slides, but I'm grateful to you, Jeanette, for inviting me and working with Justine, my colleague, to make this happen. And for everybody attending on a Monday night, it's just wonderful. So let me share my screen here. Hopefully this goes smoothly. Okay. Are you able to see that all right?
Looks
Yes,
good.
we are. Looks good.
Okay, good. Okay, so far so good. So this is a transformative time in Alzheimer's disease, and you will get to understand what I mean by that. The world is changing, not just because of COVID, but because of advances in Alzheimer's disease. And I, who have had family members I've looked after with this terrible disease, am as excited as everyone else to see some new things, some changes, some breakthroughs. So let me try and share what's going on. Let me make sure I can advance my slides there. So I'd like to provide an update on recent advances in research, new approaches to diagnosis. It's very important that we diagnose early and accurately. New approaches to treatment, what's around the corner, and then to provide an opportunity for those who wish to become more involved to connect with us and to find ways to be involved. So let's begin. Let's talk about diagnosis first. So in 1906, over 100 years ago, Dr. Alzheimer, a German psychiatrist and neurologist, first described this disease, and it was thought to be a rare disease. It was later named after him. It was named after Dr. Alzheimer and called Alzheimer's disease. And his patient, the first patient he described, was in her 50s. She looks much older in this picture. That's what this disease can do to you. But she was a young woman, and this was felt to be quite a rare, unusual disease. If we fast forward to present day, we know that this is anything but a rare disease. There are 55 million people worldwide who have Alzheimer's disease or related dementia, and the numbers are growing. It will be 75 million by 2030 and continuing on unless we figure out a way. It'll be 150 million by 2050. So we really have to get a grip on this disease. And here you see some of the famous actors and celebrities and politicians who later in life developed Alzheimer's disease. But we know that younger individuals can also develop this disease. And when we talk about young onset or early age of onset of Alzheimer's, we're talking about under age 65. Some people as young as in their 40s, often in their 50s, and about 8% of the 55 million people in the world with Alzheimer's start their symptoms under age 65. And you see on your left, John Mann, who was the Canadian rock band frontman. Spirit of the West was the band, and he died at age 57 of Alzheimer's disease a few years ago. And on your right, you see the actress Julianne Moore, who played Alice Howland in Still Alice, and she was diagnosed with Alzheimer's disease at the age of 50. And those of you who know this disease up close know that there's a terrible personal burden of Alzheimer's disease, and this disease is absolutely not for the faint at heart. It changes you, it changes your family. When this disease runs its full course, it is just impossible to see people that you love completely destroyed in terms of their ability to think and do things. So we absolutely must do something about this disease. And the World Health Organization, as early as 2012, stated that Alzheimer's disease was an urgent healthcare priority. And that continues to this day, even more so. Not just because of the staggering numbers and the severity of the disease, it is a fatal disease, but also the enormous cost of care. This disease costs more than heart disease and cancer combined, and most people don't realize how expensive it is. And despite being such a common disease, it is fraught with underdiagnosis and late diagnosis, which adds to the difficulty of doing anything about it. So 50% of people or more are never diagnosed and have this disease. And when those are diagnosed, when some of those are diagnosed, it is after several years of symptoms. So the brain has already deteriorated quite a bit, and symptoms have become pronounced before a diagnosis is made. That's not how we tend to like to do things in medicine. We like early detection, whether it's cancer or anything else. We like to detect things early because we think we have the best chance of doing something. But with Alzheimer's disease, people wait a long time until they're diagnosed. And when the diagnosis is made, it is often wrong. When we go on to confirmatory tests, in the rare case where specialized tests are performed, we see that 30% of the time, at the dementia stage, this actually isn't Alzheimer's disease. And in the mild cognitive impairment stage or the pre-dementia stage, over 50% who are said to have Alzheimer's actually have something else. So you can see this terrible inaccuracy of diagnosis and the lateness of diagnosis. That can't serve us well. And why is it that we're so bad at diagnosing this? Well, physicians aren't lazy. They are working hard. There are many factors, however. Patients themselves may not recognize symptoms and may not report them. So some people developing Alzheimer's disease are not aware of the changes, and it's those around them who might actually notice something's wrong, not the individual, him or herself. And that's through no fault of that individual. It's because the part of the brain that allows one to reflect on how one is doing is not working. But in many cases, early in the disease, people are aware of changes going on in their brain. And they are afraid to come forward because there is stigma, there's fear of loss of independence. Maybe they'll lose their driver's license if they speak to the doctor. They're fearful of having a bad diagnosis, Alzheimer's disease, and being told there's nothing we can do for you. So here we have people who are insightful that something's changing, and yet they may not come forward until things are quite distressful. And then on the physician side, physicians often lack the skill and the will to diagnose. They may be disinterested in this serious disease because it is so complex, time-consuming, and they don't have the resources to deal with it. And that's a legitimate problem. And most Canadian physicians would tell you, certainly at the family practice level, that they don't feel comfortable making a diagnosis. They're not sure how, and then they often complain, and so does the community, about how do I know this isn't just normal aging, and how much forgetfulness is part and parcel of normal aging. and when does disease start and normal aging end? So there's a lot of confusion about that and a reluctance to say somebody might be developing Alzheimer's disease when one could say, oh, well, you're just a bit forgetful. Everybody gets a bit forgetful as they get older. But is that really true anymore? Also, our cognitive tests, let's say a patient is diligent, comes to the doctor is diligent, performs some screening tests. Those cognitive tests may not be sensitive enough to pick up early disease. They may be fine if people are extremely forgetful, but in the earliest stages, the tests may not be that sensitive. And we don't have yet a blood test or a simple scan that is diagnostic. So, if somebody has chest pain, maybe having a heart attack, we do a cardiogram, we do cardiac enzymes, we have an answer. So we have relatively simple, quick, accessible ways of determining a diagnosis in that case, but not so with Alzheimer's. But what we do know is there's a huge window of opportunity because this is a very long disease and changes in the brain are going on in Alzheimer's disease for up to 20 years before there are significant symptoms. So 15 to 20 years of changes in the brain. I'll show you what those changes are in a moment. And then there are enough changes that the brain can't compensate, and we get into this MCI or mild cognitive impairment stage where people have memory symptoms, they have an abnormality in memory on their cognitive tests or in other cognitive domains, may not be memory, might be word finding, other things on cognitive tests, and yet they're still functioning independently in day-to-day life. So they can still bank and shop and travel and work or do whatever is normal for that individual. We call that mild cognitive impairment with Alzheimer's disease underlying it if it's on this continuum, excuse me. And that lasts about 5 years and then seamlessly progresses into a dementia stage of Alzheimer's disease. Dementia simply means one cannot function independently because of cognitive impairment. So when you have enough cognitive impairment, enough damage to the brain from Alzheimer's disease, you get tipped into the dementia stage, and it's not all at once. You may be able to still to drive, but not to bank, or not to bank and drive, but still to work in the garden and cook. But gradually, as the disease goes through mild, moderate, severe stages of dementia, more and more abilities are lost, such that by severe stage, people are requiring help with everything, whether it's feeding themselves, dressing, toileting, everything. So a very long disease and a huge window of opportunity when the disease is building up gradually to do something before people reach the dementia stage. And here's what's going on in the brain. This is what Dr. Alzheimer would have seen with a light microscope, looking at a slice of the brain at autopsy. These smudgy brown spots are amyloid plaque that have built up over many years in the brain. And when amyloid builds to a certain threshold in the brain, then you get another protein called tau misbehaving and forming these tangles, those little black dashed areas. And amyloid plaque is usually surrounded by inflammation, and there are other complex processes that go on in addition to amyloid and tau that you can't see on this slice. And the brain shrinks. And why does the brain shrink? It shrinks because brain cells are dying. Millions of brain cells are dying. So we're born with 100 billion brain cells, and we lose millions of them in this disease. And so you see a much smaller brain, but it's not just, throughout the brain equally. The part of the brain that is vital for memory, called the hippocampus, you can see on your left in the healthy brain, this sort of globular shaped structure where the arrow is pointing, the hippocampus. On your right, in advanced Alzheimer's disease, it's an empty cavity. There's no hippocampus. There's barely any tissue there left. So you can see why treating in the late stage of disease is not going to restore the brain. You don't have any neurons, brain cells left. So this is why we have to diagnose early. So can we do this? Can we diagnose early in the disease while people are still living, not at autopsy? And the answer is absolutely yes, we can. We have the tools to do this. I'll explain to you shortly why we're not doing it regularly, but we absolutely have the ability to do it. And we have two gold standard technologies. One is the PET amyloid scan. So that's not the same thing as a glucose PET scan or an MRI or a CAT scan. It's PET amyloid scan, PET scan with an amyloid tracer. Or the equivalent would be to analyze the spinal fluid with a spinal tap. And there we can analyze for amyloid and tau with the same sample. And why is this so important? Well, this means that in life, we can diagnose Alzheimer's, not at autopsy, and we can rule in Alzheimer's, not just rule out strokes and tumors and thyroid disease, a B12 deficiency, all the things that we do with blood work, or maybe a structural brain scan and say, well, it's not this, this, and this, so it's possibly Alzheimer's because we've ruled out everything else. Now we can actually rule in Alzheimer's and be certain about it. And as in all aspects of medicine, earlier diagnosis allows for better treatment outcomes. And here's what a PET scan tagging amyloid would look like. So you see an individual in the scanner, just the head in the scanner, and on your right, you see a section of the brain, the living brain, and you see red, and the red is amyloid. So it's very widely distributed. This is amyloid plaque. That's what a PET amyloid scan can show you. And this person may have mild cognitive impairment due to Alzheimer's disease. They may have no symptoms, or this person might have severe stage dementia. Amyloid rises very early to a high level in the brain long before symptoms begin. So from this scan, we can't stage how far along the severity of the disease is, but we can say absolutely that this person has amyloid abnormality and therefore has Alzheimer's or is on that Alzheimer's continuum.
Around. Can you hear?
And the corollary, the spinal tap, we do this in our clinic every day. It's an outpatient procedure. It's very well tolerated with a very skinny needle, a little bit of freezing in the back. We draw some spinal fluid out and send it to a specialized lab that can give us a readout of amyloid levels and of tau, and those levels reflect what's going on in the brain. And so why aren't we doing this?
Oh, Sharon, it looks like you are just muted.
Okay.
There you go.
Am I unmuted? Oh, I think maybe there is background noise and then.
Yep, you sound good.
Yep, that's good. That's good.
Okay,
Yeah.
no worries. Okay, sorry. I hope I wasn't muted too long. Sorry about that.
Oh, no. Yeah.
So the main barrier to accessing biomarkers to confirm a diagnosis of Alzheimer's are cost. And we have an approved amyloid tracer. And when I say approved in Canada, I mean for clinical use, not just for research use. Most people don't know that. Most physicians don't know. Florbetaben is an amyloid tracer. It was approved several years ago by Health Canada, but the cost is not covered. So it costs about $3,500, and a few of our patients opt for, private pay, out-of-pocket pay, but most cannot afford that. The other barrier with PET scans is we have a limited number of PET scanners. When a disease-modifying treatment, a substantial breakthrough in treatment comes to Canada, and that will be in the next few years, I predict, there will be a huge demand on PET scanners, and we will have to scale up, or we'll have to find an alternative to PET scanning to diagnose Alzheimer's disease. The limited number of PET scanners we have for our population are devoted largely to oncology, that's cancer medicine, and doing PET scans in cancer medicine has become very routine, but it's very rarely done in Alzheimer's disease. As far as spinal fluid, the cost is also not covered by OHIP, but it's not nearly as expensive as a PET scan, so many people could afford that. A spinal tap is required, which is a fairly straightforward procedure in our hands and a safe procedure. It's not generally offered. Even in most memory clinics, they are not doing spinal taps. And fluid needs to be shipped out of the country because we don't have a Canadian lab, and we're just starting to have one in Vancouver. that might be able to provide some spinal fluid analysis, but the resources are not really where they need to be. So that's what's happening. Somebody who's motivated and wants to get these tests done absolutely can, but you see the issues here of cost and access. So what do we do about this? So at the present time, if Alzheimer's disease is suspected, other things have been ruled out. If you refer a patient or if you come to a select specialty clinic like ours, we can do these tests and usually cover the cost of either the PET scan or the spinal fluid analysis through our research grant funding. So we have a workaround and we do this all the time. Within the next few years, we are very hopeful that we will have other tests that will be more accessible and more affordable to at least pre-screen, if not to diagnose Alzheimer's disease. And what will those look like? Well, we've been talking about blood tests for a long time for Alzheimer's disease, and they are getting better and better. They're not quite at the stage where we use them outside of the research setting, but this will change. And, will it be another year? Will it be another 2 or 3 years? Hard to predict, but they're getting more and more accurate. And there will be blood tests to determine amyloid, tau, and other markers. And then, then it's possible that in primary care, a family practitioner could order such a blood test and then refer a patient on to a specialist if the concern is about Alzheimer's disease. Another technology that is advancing is the use of something called ReadySpec imaging, which involves taking a picture of the back of the eye with a special camera, a hyperspectral camera, and this can detect the signature of amyloid. The back of the eye is the front of the brain. And without any invasive technology, without using any dye or anything else, we can detect Alzheimer's, if you will, or amyloid in the retina. And the validation study is well underway. The preliminary results look very good. This is something we've been working on for a few years, and we're very excited that optometrists, ophthalmologists who do annual eye exams with seniors and others may be able to participate in screening early for Alzheimer's disease and catching any changes that would suggest someone should be referred on to a memory specialist. What about genetic testing? Well, this can help with diagnosis also, and it does so in 2 ways. There are some rare gene mutations that can be detected in a blood sample. Here, fortunately, the cost is covered. Again, this is something that many doctors don't know about. Patients come asking, is there, a genetic test for Alzheimer's? And they're told, no, there isn't. Well, yes, there is. If somebody has 2 or more close relatives in the family who have or have had Alzheimer's, then it's reasonable to look for these rare gene mutations. And we do order these. They're rare. So even with, a family member with Alzheimer's, one might not have a gene mutation that's directly causing the disease. But there's also a risk gene called the ApoE gene, and it's the ApoE4 type of ApoE that confers a higher risk of Alzheimer's, and that we can detect from a blood test or a cheek swab. And again, the cost is covered. In the case of the blood test, it's covered by the Ministry of Health. The cheek swab at our clinic, we absorb the cost of that. So individuals who have risk genes like the ApoE4 gene or causative genes like the gene mutation have prevention opportunities and treatment opportunities through clinical trials. So this is important because you'd say, well, why would I want to know that I'm at risk for something? Well, we're all at risk for things. Some things we know and some things we don't. But those who are at risk often want to be proactive and do something. And fortunately, there are clinical trials for both groups, for the risk gene group and for the deterministic gene mutation group. Here's the little device, the Spartan cube that we use. It's the smallest DNA analyzer in the world. It's a 4x4-inch cube that sits on our lab countertop. And you see on your left, Kathy Barrick, who's the CEO of the Alzheimer's Society of Ontario, who came to us and said, I want to show people that this is not so scary. I'd like to have a cheek swab, and then I'll go on CTV with you, Sharon, and we'll talk about it, talk about the experience. And Kathy was saying, you know, if she has an ApoE4 allele, then she wants to join a clinical trial. You know, she wants to be part of moving the field forward. The risk for anybody with the ApoE gene is if you have one copy of ApoE4, your risk of Alzheimer's goes up threefold over the general population. If you have two copies, so if both of your ApoEs are E4s, your risk goes up tenfold. And that's a very high risk, and people generally want to do something about it. And there's a very, very promising trial, an international trial we're participating in called the Apollo E4 study, exactly for people who have two copies of ApoE4. So it's not as if there's nothing to do about it. There is something one can do about it. So all of this effort to diagnose early and accurately matters and will play out when we have new treatments that are specific to early disease, to slowing down disease, keeping people at the earliest stages of disease. So what's happening there? We know that existing medicines are not enough. We've had approved medicines that treat symptoms for the last 20 years, the donepezil or Aricept types of medicines. And these are important contributions historically, and they do help symptoms in some individuals modestly, but they certainly don't slow down the disease. They don't prevent the underlying amyloid or tau from continuing. And importantly, none of the medicines that we have on the market are approved for the mild cognitive impairment stage of Alzheimer's. So people have to get worse before they are eligible for treatment. So you have mild cognitive impairment, your memory's not right, you're still functioning independently, you have to lose some of that independent function before the doctor says, okay, I'll prescribe an Aricept type of medicine. Doesn't make sense that you have to get worse before you can get treatment. Here's what the drug development pipeline looks like today as far as Alzheimer's disease. You see concentric circles from the outer phase 1 trials, phase 2 in the middle, and phase 3 trials in the center. And every drug that is under development has to go through these 3 obligatory phases, 1 to 3. And if a drug is successful in phase 3, then the manufacturer can take that drug dossier to the regulators, whether it's the FDA or Health Canada or the European Medicines Agency, and seek approval. And drugs will drop out. You know, in phase 1, drugs will drop out. Phase 2, they'll drop out. In phase 3, many will drop out. So you only have a small proportion of drugs that make it all the way through. So it's important to have a robust pipeline. So here, 147 drugs, that's not bad. And at all stages of development, phase 1 to phase 3. And the colors that you see, well, let's talk about the wedges of the pie first. So if you look at the light green and the purple wedges, here we're talking about drugs designed to slow down the disease. That's what we mean by disease-modifying drugs. And in green, these are biologics. Biologics are large molecules that are given by intravenous or subcutaneous injection. And in the purple, that wedge of the pie, these are small molecules that can be taken by mouth. So they have that advantage that they could be packaged in a capsule or a pill if they cross the finish line and are approved. So 2/3 or more, when you look at the actual individual number of drugs, 2/3 or more of the drug development pipeline is devoted to disease-modifying drugs, slowing down the disease. Whereas in the orange and the blue, we have symptom treatments. It's important to treat symptoms. We want to treat symptoms more effectively than we do now, but we would sure like to catch the disease earlier and slow it down. So we have symptom treatments, we have disease-modifying treatments. And now if you look at all of the different colors with the different shapes, these individual compounds that have funny names or numbers, what the colors represent is how the drug acts. And everything that's in red is acting on amyloid, either amyloid plaque or an earlier form of amyloid that may be even more toxic to the brain, soluble amyloid. Everything in blue is acting on tau, either removing tau or preventing its formation or acting on it in other ways. So blue is tau, and everything in yellow is dealing with inflammation in the brain, either quieting inflammatory cells that might be damaging the brain or revving up some of the immune cells to better clear toxins from the brain. So a whole host of different mechanisms. And in fact, more of the pipeline is devoted to the immune system than any other mechanism. There are other colors and other mechanisms. I won't go through these all, but you can see that we have a robust pipeline, phase 1 to phase 3, lots of different compounds tackling the disease in multiple ways. That is very, very hopeful in and of itself. And a fairly large number of drugs in phase 3 that will be reading out soon. So not only do we have drugs at all stages of development, phase 1 to phase 3, we also have clinical trials that are positioned not just at the dementia stage of the disease, the way they were in the past, but also at the mild cognitive impairment stage, at the earlier preclinical or pre-mild cognitive impairment stage, and those are prevention trials. So we're spanning the Alzheimer's continuum with the majority of drugs being developed for the mild cognitive impairment and the mild dementia stage. And collectively, we call that early Alzheimer's disease. So mild cognitive impairment and the mild dementia phase of Alzheimer's disease is referred to as early AD. And we'll refer to that later. So anti-amyloid antibodies can clear amyloid dramatically. And this comes from Nature magazine 2016, the phase 1b study of aducanumab, where for the very first time, we saw somebody who had a head full of amyloid, and after 12 treatments with aducanumab, had no amyloid left. So this was a dramatic finding. And based on this, and based on the phase 3 readout several years later, in June 2021, the FDA approved aducanumab using the accelerated pathway. So based on its ability to clear amyloid with the presumption that that would also confer clinical benefit, meaningful benefit to the patient. And this launched us into a new era in Alzheimer's treatment. Now, aducanumab came to the market, unfortunately, with all kinds of controversy, and the uptake has been slow, although it is being prescribed in the US to some degree, to a limited degree. But just to put it in its historic perspective, this was the first drug approved for Alzheimer's in 18 years. There had been a huge drought of new drugs. It's the first biologic drug ever for Alzheimer's disease, and we have biologics in, rheumatoid arthritis and migraine therapy and multiple sclerosis and, hematology, and we've had nothing in Alzheimer's. It's given by monthly intravenous infusion, which is completely different from how the Aricept type symptom treatments are given. So that's something new and requires a rethinking of how we practice Alzheimer's care delivery. It's treatment based on the underlying biology, early changes in the brain, with the goal of slowing the disease at an early stage. And the early stages are the mild cognitive impairment and mild dementia stages of Alzheimer's. And so, despite the controversy over aducanumab and the slow rollout, fairly soon after the FDA granted approval to aducanumab by the accelerated pathway, it also granted what they call breakthrough therapy designation to 3 additional anti-amyloid drugs that looked very promising. And these have, over the last year, since 2021, been playing out. Lecanemab, some of you might have heard a very important press release, September 27th of this year, and I'll talk about that a little bit, because that is sort of the next thing coming. But lecanemab, donanemab, gantenerumab, they're all funny names. They end in mab, which is short for monoclonal antibody, but these are all directed against different types of amyloid. And each of these drugs have demonstrated that they can clear amyloid, They are each in phase 3 of development for this early stage of Alzheimer's, the MCI mild dementia phase. They're also under study for Alzheimer's prevention at that preclinical stage where people are cognitively normal, and a very high probability of regulatory approvals in the next year for some of these drugs. And we'll talk a little bit more about that. So there's a major opportunity for those at risk of Alzheimer's to access these drugs through the ongoing prevention studies. I'll talk a little bit more about that. But let me just say that the press release with the top line results from the lecanemab phase 3 study, it's called the Clarity AD study, showed that lecanemab in this large study, 1,795 participants, it was a global study, people treated for 18 months with intravenous infusions every 2 weeks of this antibody, lecanemab, at a fixed dose, 10 milligrams per kilogram, or placebo. They were able to show that the primary endpoint, so the main goal of the study, and all of the secondary endpoints, so all of the other things that they wanted to affect change on, were met. They were successful in these endpoints, comparing the actively treated lecanemab group with the placebo group, and at a very high statistical level of significance. And the changes that were seen, both on the clinical endpoints and amyloid lowering, started as early as 6 months into the treatment. And of course, the study ran for 18 months, and the effect of treatment grew for each of these endpoints over time, was seen first at 6 months and then became a larger effect over time up to the 18-month mark. So here's a bit of technical stuff, and please bear with me. I won't belabor this, but I know we have a bit of a mixed audience here for some of the healthcare providers. The primary endpoint for Clarity was the clinical dementia rating scale, sum of boxes. And here what was seen is 27% slowing of disease at 18 months with a p-value of 0.00005. So again, for those of you who know statistics, this is highly statistically significant. And for those of you who don't like numbers or statistics, what you need to know is this result didn't happen by chance alone. This happened because of a drug treatment effect. And so this scale, it doesn't matter what it's called, it happens to be called the CDR sum of boxes, is a scale that takes into account input from the patient. So what the patient says, testing the patient, what the care partner has to say about how the patient's doing, and what a skilled practitioner, not just a researcher, but a skilled dementia clinician has to provide in the way of input. And so this is a very meaningful type of endpoint in a clinical trial because it takes these 3 stakeholders' points of view into how the score is derived. And then the other endpoints were to do with day-to-day functioning or cognition, depending on the scale. So again, we saw very consistent results with these top-line results being delivered in the press release. And as far as the safety of these drugs, there's something called ARIA, which is amyloid-related imaging abnormality. Amyloid-related imaging abnormality refers to the fact that when you remove amyloid, and this is seen with most anti-amyloid antibodies as a class, when you remove it on a scan, an image, MRI imaging specifically, you can see either some swelling or some microbleeds because the blood vessels become a little bit leaky. And most of the time, ARIA is without symptoms and resolves spontaneously. But in the top line, lecanemab results, symptomatic ARIA of the brain swelling type occurred in 2.8%. So that's much lower than what we've seen with other anti-A-beta antibodies. So very acceptable rate. With the ARIA-H, 0.7% of people were symptomatic. So again, this speaks to the fact that you need to be aware of and monitor for these findings, but that they rarely become symptomatic. So that speaks to the safety record of this drug. So what's next for lecanemab? So I've had people call my office and say, okay, how do I get a hold of this? And so we're all excited about it, but the FDA has to approve it first, and then other regulators, Health Canada, have to approve it before, the top line results. Those are the clinical trial results. Yes, it's phase 3. The FDA says that's a confirmatory trial, but now they have to review all the data and decide whether they approve the drug for clinical use. And the FDA has committed to January 6th as the latest date that they will render a decision. So that's around the corner. And submissions, so that'll be conditional approval with the accelerated pathway, and then there'll be another submission to the FDA for full approval, and that's expected by March. And the problem with conditional approval is we've seen in the US that the Centers for Medicare and Medicaid won't cover a drug if it's approved by the accelerated pathway conditional approval. So that's why it's necessary to go for full approval. And sorry, that's a lot about what goes on in the US, but it does affect us in Canada and the rest of the world. So that's why I mention it. Submissions to other regulators in other countries are at various stages of preparedness. So submissions in Japan, to the European Medicines Agency in Europe, and to Health Canada, various different stages, but we are hoping that we'll have a completed submission in Canada in 2023. More details than what were released in the top line results will be presented at a major conference called CTAD in November, end of November, and then there will be a peer-reviewed publication. So people will be diving into this lecanemab story in great detail, and you'll be hearing more and more about this drug. And so what else can we expect for lecanemab? Well, there are multiple other studies that are currently underway to expand the treatment options. So if lecanemab is approved, it will be for the mild cognitive impairment and mild dementia phase of disease. It won't be for prevention. It won't be for people who are cognitively normal. It won't be for people who are in moderate stage Alzheimer's disease. That will be considered too late, and we don't know that the drug will slow down disease at that stage. So what are some of these other studies? Well, there's a maintenance dosing study looking at, once you've removed amyloid substantially, do you need to be treated every 2 weeks, or can you stretch out the treatment to monthly or every 3 months or every 6 months? So we'll learn a lot from that dosing maintenance phase study. Then there's a subcutaneous formulation being studied, meaning perhaps you could be self-dosed at home the way people give themselves insulin. You take an injection every 2 weeks at home rather than having to come to an infusion center and have an intravenous setup. So that will be very important to see how that plays out. Then there are combination therapies going on. For example, a study where lecanemab, an anti-amyloid agent, will be used in combination with an anti-tau treatment, since we know both of these toxic proteins are important in the underlying pathophysiology of Alzheimer's disease. And so in the DIAN trial unit, which deals with autosomal dominant or strongly inherited Alzheimer's disease, lecanemab has been chosen as the background anti-amyloid therapy. So that will be very interesting to see what the combination anti-tau, anti-amyloid therapy yields. Very relevant for the Canadian population is the fact that there is an Alzheimer's prevention study. There are a few Alzheimer's prevention studies going on, but the one with lecanemab is called the AHEAD study. And we have that study at our center, and a few other centers across Canada have this study. And this is for people who are cognitively normal. They may have subtle cognitive symptoms. They may have Alzheimer's risk factors like a family member or an ApoE4 carrier status. And prevention is so important. So here's Benjamin Franklin. He wasn't talking about prevention in medicine. He was talking about preventing fires in Philadelphia in the 1700s. But this ounce of prevention is worth a pound of cure is something that we adopt in medicine all the time. And so if you can, prevent dementia, prevent mild cognitive impairment stage of Alzheimer's, all the better. So the AHEAD study, the goal is to assess the ability of lecanemab to slow progression of preclinical Alzheimer's. So there's amyloid in the brain, but people are still cognitively normal. And we want to slow down the progression or halt the progression to mild cognitive impairment and dementia stages. So keep healthy people healthy. The study is a public-private partnership between ASI and the National Institutes of Aging. It's a global study. It's a registrational study. That means it will serve as a phase 3 pivotal trial that the manufacturer can take to regulators to get approval. And the screening is open to people who are 55 to 80 years old, and with or without family history or ApoE4 gene carrier status, or prior PET or spinal fluid positive for amyloid. So those are things that are helpful in that younger decade, the 55 to 64. We need an additional risk factor, but we have screened. We have in screening, over 100 individuals for this study. It is very, very sought after. So I think that if lecanemab is approved by the FDA in January, this study will fill up quickly. If any of you are interested in Alzheimer's prevention, find out about it, contact us, because it'll be a limited window of opportunity to access this opportunity with lecanemab. And here, this is where the AHEAD study fits in this preclinical stage before the MCI stage. And people might have subtle symptoms, but their cognitive testing is still normal. And so who's at risk for Alzheimer's? Well, any of us over age 65, this is an age-related, not age-caused, but age-related disease. Anybody with a family history, anybody who has an ApoE4 allele, people with subtle cognitive symptoms may be at risk for Alzheimer's, and then others with gene mutations, people with trisomy 21, which is Down syndrome, and then other conditions that lower cognitive reserve. So it's a long list, but we're dealing with a common disease, and as we get older, people are often interested in what they can do to prevent developing Alzheimer's. This is an awesome opportunity, participating in the AHEAD study, to access a PET scan without cost, to learn one's amyloid status. And if one's amyloid negative, that's great. You go no further in this study, that's just good news, and you sit with that. If one is amyloid positive, if amyloid is starting to accumulate, then one has the opportunity to go on to the treatment with lecanemab within the study, with regular contact with an expert team and satisfaction of knowing one's doing everything possible to help oneself and one's family and to advance science. There are many other anti-amyloid approaches that don't involve antibodies. And anybody who thinks the amyloid hypothesis is dead and that amyloid as an approach to treating Alzheimer's is done is completely misled. The Apollo E4 study I referred to a little bit earlier, this is with an oral drug that prevents aggregation of soluble amyloid before it gets to the plaque form. And the phase 2 study press release was very recent. It was September 20th, 2022, just a week before the top-line Clarity lecanemab results. And it showed cognitive improvement at 1 year, not just disease slowing, but actual improvement in a mild population, preservation of hippocampal volume, so that vital structure in the temporal lobe was not shrinking with treatment in the Apollo E4 study, and a very large biomarker effect downstream on tau. So really promising phase 2 results, and the phase 3 study is going on in centers like ours and others. And again, it will wrap up its enrollment fairly soon because it has been looking so promising. Another approach, a study called Refocus ALS, is in phase 3. And this is one of the less common studies focusing on individuals with mild to moderate stage Alzheimer's. And I'm very, very glad whenever we have opportunities for people who are a little further along in the Alzheimer's continuum, because they absolutely deserve treatment as well. And this drug is very interesting drug, simufilum, it's called, is also in a tablet form. And it impacts both amyloid and tau in a unique manner. And the phase 2 results upon which the phase 3 study was built showed improvement on 11 different Alzheimer's biomarkers. So very widespread impact on the Alzheimer's biology. So it looks also very promising. And then, still more, there are other approaches looking at gene silencing. And this is a phase 1 study where at Toronto Memory Program, we've actually enrolled the first cohort single-handedly for this phase 1 study with a very unique class of drug that turns off production of all amyloid at the RNA level. So it's interfering with the gene that's responsible for production of amyloid. And this is very exciting and may lead the way to a completely new class of drug therapies. And usually in phase 1, you don't get open label extensions, but in this study you do, and it's for people with young age of onset of Alzheimer's. So again, another unique facet of this trial. Anti-tau studies, there are many. I won't go through them now, but they are ongoing. And as I mentioned several slides ago, harnessing the immune system to tackle Alzheimer's disease is the largest portion of the pipeline. So we may see drugs that tackle inflammation, boost immune cells, and boost protective functions of support cells coming to fruition in the next few years. So looking after one's brain health requires, paying attention to lifestyle strategies, undergoing a risk assessment. What does my genetics say? What's in my family history? Am I at risk for Alzheimer's? And then considering clinical trial participation. So up to 35% of dementia might be preventable through lifestyle modification, staying mentally active, physically active, being attentive to dietary pattern, quantity and quality of sleep, managing stress, controlling what we call vascular risk factors. These are things like high blood pressure, diabetes, smoking. But we know so many people who live well and do everything right, and it's very unfair, but they still develop Alzheimer's. So, when you're young and you're able and throughout the lifespan, yes, absolutely, one should embrace a brain healthy lifestyle strategy, but that is absolutely not going to be enough. It's not enough to say to people that you can prevent cancer by living well. You will reduce your risk of cancer, but it's not enough. When people get cancer, which they will, even if they've lived well, you need cancer treating and curing medication. So, as I've said before, reasons to join a clinical trial include access to specialized diagnostics, and we do have specialized diagnostics now, access to cutting edge treatment without cost, treatments that are not otherwise available, access to expert team of specialists and close monitoring of one's condition, and the satisfaction that one's doing everything one can for oneself and one's family and for future generations. And all of the drugs that are in the pharmacy, whether they are for diabetes, for COVID treatment or vaccination prevention, for any disease, come about because medical heroes in everyday life participate in clinical trials. And I think, unfortunately, clinical trials tend to be undervalued, but they are the hope for the future. And these medical heroes, you see, whether they're taxi drivers or, university professors or caretakers, they come forward. And without them, this is what the pharmacy would look like. There would be no drugs for any disease. And so when we go pick up our prescriptions for whatever it is at the pharmacy, we often don't think about all those clinical trial participants around the world who made those drugs possible. But I think it's worth taking a moment to think about that. So don't doubt progress in Alzheimer's disease, help accelerate it. people like you and I who know this disease want to be involved, you can have a baseline memory test. You can join our prevention and treatment registry, have a cheek swab, find out if there's a clinical trial that's right for you or somebody that you care about. And we all have a role to play. So I really encourage you to be involved and do it for yourself, do it for next generations. And you're more than welcome to get in touch with us. I wish that we had a satellite center in each of your geographies. Unfortunately, we're in the big city, not downtown Toronto, though. That's good. And free parking if you can put up with coming to North York. But reach out to us virtually if you like, or by phone, and see if there's anything that we can do to be helpful to you. So I'm very happy to answer questions of any kind. And I'll stop sharing my screen now so that maybe I can see some of you and you can ask me your questions.
Thank you so much, Dr. Cohen. That was so interesting. It always feels so hopeful to see what is in the pipeline, to see what is making it through clinical 3 trials. You know, there are going to be changes to the way we treat Alzheimer's disease, and it's all about getting involved with research projects, and who knows what's coming up soon. So that is wonderful. Thank you so much.
You're so welcome.
I also wanted to introduce Justine, who is here from Dr. Cohen's program. If you have questions, you can send them to me. You can also send them to Justine Riom. She is also a co-host. So if you'd rather send them to Justine, that is totally fine. I'm going to do a quick station break. We already have some questions for you, Dr. Cohen, as well as there are also lots of, thank you so much for the wonderful presentation. So again, make sure you get your questions to me or to Justine. If you want to unmute and ask a question, that would be okay too. Before we get to the Q&A part, I do have a couple of things I wanted to mention. First of all, I do need to mention a program we have, Finding Your Way, as well as dementia-friendly communities. This is a program that is offered through our society and all of the chapters across Ontario. We provide resources to help improve safety in our community for everyone, including people with dementia. And if you're interested in finding out more about Finding Your Way, please contact the Alzheimer's Society Huron Perth or a local Alzheimer's Society chapter near you. The other thing that I did want to share, on our website, the same place where you guys signed up for this program today. Can you see this on here? On our website, we have what is called Education Hour. If you click on there, you can see all of these 1-hour programs that are available. They are free. Some of them are in the morning, some in the afternoon, some in the evening. You do not have to be a client of the Alzheimer's Society to take these courses. So if you are interested in finding out more, please join us for one of these. One question that I did have come through is, what is the difference between Alzheimer's disease and dementia? Alzheimer's disease is a type of dementia. There are many different types of dementia. Alzheimer's disease is the most common one. That actually is something we will be talking about on November 14th at Types of Dementia. We also have 10 warning signs. What is MCI? Mild cognitive impairment is coming up soon. If you'd like to register, you can simply click here or go here, and that takes you right to the Zoom link. So again, Education Hour. You can get there at alzheimer.ca/Huron County or alzheimer.ca/Perth. We would love to see you there. Okay. So I have a couple of questions here. These are great questions. One of the questions I had is, are amyloid plaques only present in Alzheimer's disease? Are they involved in other types of dementia as well?
Yeah, that's a great question. So if one has amyloid plaque, then one has the biologic hallmark of Alzheimer's. And there are some other conditions where amyloid plaque occurs, but we still consider this Alzheimer's disease. So something called CAA, cerebral amyloid angiopathy. It's a hereditary condition, can occur in young people and present with stroke, but these people also have the dementia, or will develop the dementia of Alzheimer's disease. So yes, amyloid occurs in the brain and signifies that that brain is on the Alzheimer's continuum. And then it takes a clinical assessment or other biomarkers to determine if the person's symptomatic or not. And if they are symptomatic, do they have mild cognitive impairment or the dementia stage of Alzheimer's? Because Alzheimer's disease is so common, and because amyloid rises early in the brain before symptoms, there is a misunderstanding that in a certain proportion of individuals, amyloid is normal. If you let amyloid brew long enough, one will progress to dementia, but depends on when one develops amyloid. So if you're in your 80s and starting to accumulate amyloid, and a heart attack or stroke or something else carries you off, or cancer, you didn't have time to develop Alzheimer's, you say, well, that's maybe a good thing. But this is where the misunderstanding comes, that it is not a good thing to have amyloid in the brain. That's not benign.
Thank you. Another question I have here is Alzheimer's affected by the inflammation that is caused by a faulty autoimmune system?
There's increasing evidence that the immune system plays a role in Alzheimer's disease, and that certain types of treatments that influence the immune system may be beneficial in slowing down the disease. So the earlier thinking was that as amyloid accumulates and the brain is injured, then you get inflammatory cells reacting to amyloid plaque. Others have turned this on its head and said, no, the immune system is disrupting the brain very early and contributing to the amyloid pathology and other changes in the brain. And there is some evidence. We don't understand entirely the interplay, but I think it is fair to say that the immune system has a role probably from the beginning to the end of the disease, and maybe an evolving role. I talked about the ApoE4 risk gene. There are about 24 risk genes that are known, and many of them are genes that have to do with the immune system. And this is one line of evidence that Alzheimer's disease is an immune disease.
Okay, thank you. I know the immune connection is certainly something that we get lots of questions about. So thank you for that.
I'll just add that, the idea that the immune system was important was considered, 1 or 2 decades ago when I started in research. There were the trials with the NSAIDs, so those are the aspirin, naproxen kinds of drugs, and then a stronger immune modulator, prednisone, and those trials didn't work out. And it was early days testing the immune system with those classes of medicines, and those are not the immune modulating medicines that are being tried now, when we're having what we think is more success, perhaps, tackling the immune system. So there was originally an idea the immune system was important, inflammation was important, then it was abandoned, and now it's having a resurgence with new approaches.
Okay, great. I have another question about family history. So what type of family history is required connected, such as a grandparent with dementia or a parent with dementia? I know you touched on that briefly, but maybe you could
Sure,
expand on that a little
sure.
bit.
So if you have a first degree relative, and I'll explain what that means, with Alzheimer's disease, you share 50% of your genes with a first degree relative. So a first degree relative is a parent, a sibling, so brother or sister, or a child. If we go to grandparents, those are considered second degree relatives, and we share 25% of our DNA with them. So it's the first degree relatives that tell us the most about our risk. So if I have a parent with Alzheimer's disease, that doubles my risk, my age-related risk of Alzheimer's. Now, other things go into the risk mix, including my age and my education and my sex and whether I have an ApoE4 carrier status and things like that. But just by first degree relative alone, I've doubled my risk. That's not the case if my parents were fine and my grandparent had the disease. However, think about this. If mom had Alzheimer's and mother's mother had Alzheimer's, so yes, that's a second degree relative, but now we've got two generations, and maybe mother's sister, so a maternal aunt had Alzheimer's. That's starting to look like a strongly inherited type of Alzheimer's running through the family. So remember I said if you have two or more relatives in the family with Alzheimer's, particularly if they're on the same side of the family and over successive generations, then cumulatively that starts to look like the situation where one might want to be tested for a deterministic gene mutation. So we look at the whole pedigree and try and figure out what the risk implications are.
Thank you. I have lots of questions rolling in now. I did want to mention that Justine did put the link in the chat box for anybody interested in contacting the Toronto Memory Program about getting involved in a study. So make sure you check that out if that is something that you're interested in. Very important. I have another question here. Someone's 63-year-old husband is on, I might say these medications wrong, you probably know them, Revizitine and memantine. How long are those types of drugs effective for?
Yeah, thank you. And whoever asked that, I guess it looks like Linda, if that's your name. Thank you for sharing personal information. I do appreciate it. So yes, rivastigmine and memantine are symptom enhancing medicines that have been available for about 20 years for Alzheimer's disease. And they work from the mild dementia stage right through to late stage disease. The problem with these medicines, well, I should say that's a good thing. So there isn't a point where you have to stop the medicine. If it's been helpful from the start, it is probably still working. The troublesome thing about these medicines is that people still continue to progress in their disease because these medicines don't tackle amyloid or tau. They work on the dying brain cells and they boost the neurotransmitters or the chemicals in the brain. So they work rather late in the pathology of the disease, but they continue to work. And we used to think in the early days of these medicines that after 6 months, somebody's getting worse, maybe the medicine's not working anymore, we'd stop the medicine and then people would dramatically plummet. And we'd say in retrospect, oh, I guess the medicine was doing something. So we don't do that experiment anymore. If someone got some benefit initially, we assume they're continuing to get benefit. And the only reason we'd stop the medicine is if there were side effects. For memantine, that's in a different class than rivastigmine. Memantine has a formal indication for moderate to severe stage dementia due to Alzheimer's disease. So it is absolutely a medicine to continue on into later stages of disease.
Thank you. I have another question. I believe this is perhaps from a healthcare professional. If we wanted to order the OHIP covered APOE4 blood test in an outpatient clinic, is this added to the Ontario lab requisition, or is there a special requisition required? Again,
Yeah, thank you. It's
yeah.
a special requisition. It's not on the usual physician lab recs. We request cost coverage through the Ministry of Health, and there's a particular form. I'm happy for us to send that to you if you want to either get in touch with Justine, email us, or me. We can provide that. We use Prevention Genetics as the lab. There are other labs. So we actually draw the blood in our clinic. We submit an application for cost coverage approval. Once we get that approval, then we send the blood specimen to Prevention Genetics lab. So it's a bit of a rigmarole, not so much for the patient, but you need the ability to hang on to the blood specimen.
Oh, that's
Otherwise,
excellent.
you would wait until you have the cost coverage approval and then bring your patient in to do the venipuncture.
My next question here. If someone has MCI from a lacunar infarct stroke, can you still enter an Alzheimer's disease research study? So it'd be more of a
Yeah, that's an
vascular.
interesting
Yeah.
question. So small strokes in the brain, we call them lacunar strokes if they're less than 1 centimeter. So anything under 10 millimeters is considered a lacunar infarct or stroke if it's in the white matter generally of the brain, not always the white matter, but usually deep in the brain. And sometimes people get diagnosed as having vascular dementia when these are seen on a scan. But most of the time, that's not really correct according to formal criteria for vascular dementia. And these little lacunes are common, and you're allowed a certain number of them to enroll or participate in an Alzheimer's clinical trial. So if you had lots of them, probably not, but if you had 1 or 2, most of the time, that's fine. You would still be eligible to screen for an Alzheimer's clinical trial. So it depends a little bit on how many and where exactly the lacunar stroke is. If it's in a critical area, I'm talking technically here, if it's in the left thalamus, that might not be okay, but if it's in the right parietal lobe, might be fine. So again, I'm talking technical here, but this is the kind of thing we can easily sort out for you if we can access the scan.
And I have kind of a similar question that came in. Someone asked, can you take these Alzheimer's medications if you have a history of seizures?
So it depends on how well controlled the seizures are. The symptom treating drugs, like the Aricept drugs, donepezil drugs, they can lower the seizure threshold a little bit. So one would be cautious as a prescribing physician to start someone who had epilepsy on a medication that might lower the seizure threshold and make it more likely that somebody would have a seizure. It's not an absolute contraindication. If somebody's epilepsy is very well controlled and there haven't been recent seizures, then it might be worth, taking a careful try. But it's not as straightforward a situation as somebody who doesn't have epilepsy.
Great. I have another question here. Somebody has been in testing and the MOCA test didn't reveal any issues. However, I'm certain she's certain, or they are certain that their brain is not working properly. They're booked for an MRI. Is the MRI, would it still be useful in identifying dementia?
Okay, so, this is something we see all the time, that people may feel something's changed in their memory. They're not the same, and they tell a very cogent story, and I believe my patients. But I might do the MOCA, that's the Montreal Cognitive Assessment, and the score is normal. So what I tell my patients is, I'm very glad your score is normal, But the question is it normal for you? Are you somebody who would, normally be, 35 out of 30 on this test out of 30? I mean, we can't measure that, but if you think of Einstein and how much his brain would have to deteriorate before he started to show abnormal scores, you get my drift here. So people can notice changes in themselves before our routine tests are sensitive enough to pick this up. In our research trials, we have more sensitive tools, but nevertheless, the MoCA is a reasonable thing to try. And having normal cognition by the MoCA does open the door to screening for a prevention trial if one is interested in moving on to a PET scan and seeing whether amyloid is accumulating. So one wouldn't have dementia. To have dementia, you have to have impaired cognition that I can see on an objective test, and it needs to be impaired to a degree that it's affecting your independence and day-to-day function. But it is reasonable to say, am I developing Alzheimer's? Is that amyloid protein accumulating? And so that's something that screening for the AHEAD study would be ideal for.
Thank you. Is there a relation between amyloid growth and blood sugar or insulin in the blood?
It's not a direct relationship between amyloid and insulin, but some people feel that in Alzheimer's disease, there is a mishandling of glucose by the brain, and that insulin treatment might actually be a reasonable approach. So there have been trials with intranasal insulin delivery. They're not conclusive yet, so we don't really we're not on firm ground now to say that drugs that deliver insulin will treat Alzheimer's disease. But there are other diabetes drugs. Semaglutide is a common one that's been around and prescribed to millions of people around the world and is now being tested in Alzheimer's disease in a phase 3 study, not so much for its glucose modifying effect or its diabetic effect, but because it has a modulating effect on neuroinflammation. And so the story is quite complicated, but insulin levels and amyloid are not going to go hand in hand very easily.
Thank you. Another question is, are there trials for other dementias? So other types of dementia other than Alzheimer's disease?
There are, but they are much less abundant. And that's a shame because less common dementias are still bad diseases and need better treatments, whether it's frontotemporal degeneration or Lewy body disease. What we are hoping is that breakthroughs in Alzheimer's disease will lead the way to help us with some of these other diseases. And so, for Lewy body disease, frontotemporal degeneration, we don't yet have the diagnostics at the same level with spinal taps or PET scans being able to show us that the brain changes, and therefore it's hard to develop drugs and know that they're targeting those changes. But I think, there are some trials in Parkinson's disease dementia and Lewy body dementia. There are some trials with the equivalent of anti-amyloid drugs. They're anti-alpha-synuclein drugs, which are tackling the protein alpha-synuclein, which makes up the Lewy bodies. It's earlier days for the other dementias, unfortunately, but we recognize that these are serious diseases and important diseases to tackle.
Okay. And another question on the same area of other diseases. One person is asking about her husband was diagnosed with Parkinson's, although he is not taking any Parkinson's treatment yet. his mother had Alzheimer's disease, which started in her 50s. This person is just noticing that her husband's mobility has changed quite drastically in the past 3 to 4 months. Um, and, trouble with word finding as well. Would he be a good candidate for testing a PET scan?
Yeah,
I guess. Yeah.
that's interesting. So if one has a parent who's had young onset Alzheimer's, that is a little bit suspicious for a gene mutation causing, or more strongly, hereditary type of Alzheimer's disease. Because the genes that cause Alzheimer's disease tend to produce symptoms at a younger age than sort of common variety Alzheimer's. Now, in young onset Alzheimer's disease, more often than late age of onset, there can be Parkinson-like features. So it begs the question, what is going on? Is this young onset Alzheimer's? Is this Parkinson's disease plus Alzheimer's disease, or something, a third thing that could account for all of the symptoms? So a PET scan would be clarifying, yes.
Okay. Thank you.
It would clearly rule out the amyloid Alzheimer's factor or rule it in. So it could clarify that component.
Okay. The next questions are about getting involved in research. There's a couple that I can put together here. One is, if you live in Huron County, how do you get involved in research? And then the other one is, how long are the visits in Toronto? Maybe how
Yeah.
often and how long do they last?
Yeah, these are great questions. So, unfortunately, trials tend to be centralized to large centers where we have more resources, but everybody across Canada deserves trial opportunities. And one thing about clinical trials is we often have cost coverage for our participants for transportation, or can arrange the transportation and absorb the cost. So that's good. And some of the visits can be done remotely, depending on the trial. Some of the scales and other things can be done by virtual links, but other visits would require that people come on site. Again, depends on the trial, but we're very aware that we ask a lot of people, including, regular visits. In some trials, visits are every 3 months, so they're not so onerous. In other trials, they're every 2 weeks, as you've heard, so that's quite onerous. Someone in Huron County, or, we have people who come to us from Ottawa or even out of province to join clinical trials that are not available in their own geography, and we welcome people. We don't have any catchment area that prevents us from taking people from other locations, and we try to cover transportation and manage schedules so that it's reasonable. So yeah, I hope that answers the question fairly well, but yeah, reach out to us if you want to hear more specifics. And when anybody's coming from out of town, we always try to pick a trial that's the least burden, least number of visits, taking into account the burden of travel.
Okay, thank you. I have one last question, unless Justine, do you have another question?
Nope, you got them all.
Okay. Another question, the last question I was going to ask is, what are the side effects, or do they know any of the side effects of the new drugs, maybe referring to lecanemab?
Right. So the main, I know I didn't spend very long on this. I didn't want to get too technical, but since you asked, I'm happy to spend whatever time. So the main side effect to be respectful of with anti-amyloid antibodies is what we call ARIA, amyloid-related imaging abnormality. It's an imaging abnormality because it's something we pick up on an MRI scan. We monitor for it, and we see ARIA develop and then recede spontaneously and very rarely be symptomatic. Nevertheless, we don't want it to be symptomatic. The commonest symptoms would be headache, dizziness, maybe visual disturbance. Again, transitory, resolves on its own, but what we don't want is it to become more serious. So we might hold dosing with these medicines until symptoms resolve or the MRI shows clearance of the change on the MRI scan. So what we've seen in the lecanemab story, the top line results, is that the amount of ARIA, the rate of ARIA, is quite reasonable. When I say that, I mean it's in keeping with what we saw in the phase 2 study, not higher, and we wondered if it might be higher for certain reasons. And it's not as high as with some of the other anti-amyloid antibodies. So this is very encouraging that lecanemab right now seems to have one of the lowest rates of ARIA. Of course, we don't have all of the sort of head-to-head comparisons available, certainly not in phase 3, but the phase 3 lecanemab ARIA side effect looks quite manageable. So this is good news, and there aren't other side effects other than infusion reactions. If you give an intravenous infusion, some people are going to have a small proportion might have fever and chills, and so we would pre-medicate with Tylenol or something like that.
Okay, great. Thank you. Aria, I hadn't heard of that myself, so that's very interesting. Okay, well, it is going on to 8:30. I just want to thank you, Dr. Cohen and Justine, for coming out and being with us this evening. I know we all learned a lot. And I wanted to thank everybody who joined us as well. It's always great to see that so many people in our community are, really eager to find out more about this information, how to better support people with Alzheimer's disease, new treatments, new directions. So anyways, thank you everybody for joining us this evening. We will
Thank
try to
you.
have, yes, yeah. Enjoy the rest of your evening.
You too. Thank you so much for having me and for all the great questions and engagement. Take care, everyone.
Great. Good
Thanks,
night.
everyone.